Here is something that genuinely surprises most people the first time they hear it. Two people can have pain in exactly the same anatomical location, describe it in almost identical terms, and have completely different conditions that require completely different treatments. This happens not occasionally but routinely, and treating the wrong condition or assuming you have one thing when you actually have another is one of the most common reasons people remain in pain despite receiving well-intentioned treatment. Let me take you through several examples that illustrate just how significant this diagnostic overlap problem actually is. Start with shoulder pain. Pain on the outer aspect of the shoulder, aggravated by reaching overhead or lifting the arm away from the body, could be subacromial impingement syndrome, a partial or full thickness rotator cuff tear, acromioclavicular joint arthritis, biceps tendinopathy at the long head, or referred pain from the cervical spine at the C5 or C6 nerve root level. That is 5 different conditions producing pain in essentially the same location with many of the same functional limitations. Subacromial impingement responds to specific exercises that restore the normal mechanics of the shoulder during overhead movement, reducing the impingement. A full thickness rotator cuff tear is unlikely to resolve with exercise rehabilitation alone and may require surgical repair before physiotherapy. Cervical referred pain requires treatment directed at the neck, specific joint mobilization, neuromobilization techniques, cervical stabilization exercises, and treating the shoulder aggressively when the pain generator is actually the neck produces minimal improvement regardless of how well the shoulder treatment is executed. Correctly identifying which of these 5 conditions you have is not something a symptom checker or a general search can reliably do. It requires a clinical assessment with specific provocation tests. The clinical tests that distinguish overlapping presentations include specific provocation tests designed to stress one structure without loading the adjacent ones, movement patterns that identify where in the movement chain the dysfunction originates, and neurological screening that locates the level of nerve involvement when referred pain is the mechanism, none of which a symptom checker can replicate. Now consider knee pain on the inner side. This could be a medial collateral ligament sprain, medial meniscus injury, pes anserine tendinopathy, medial compartment osteoarthritis, or referred pain from the hip at the L3 or L4 spinal level. Each has different aggravating activities, different examination findings, different responses to loading, and different recovery timelines. A medial meniscus problem treated with the loading protocol for an MCL sprain, which involves progressive stress through valgus loading rather than the rotational precautions a meniscus requires, can delay recovery substantially. Hip pain is perhaps the most dramatic example of this diagnostic complexity. Pain perceived in the hip region could originate from the hip joint itself, labral pathology, osteoarthritis, hip flexor tendinopathy, from the lumbar spine via L3 or L4 nerve root referred pain, from the sacroiliac joint, from the greater trochanteric bursa, or from the proximal iliotibial band. Patients with L4 nerve root compression from a lumbar disc herniation regularly present with pain they describe as being in the hip, and some are treated for hip conditions for several months, while the actual disc pathology at the lumbar spine continues progressing unaddressed. The elbow is another example. Lateral elbow pain diagnosed as tennis, elbow, may instead be referred from the radial nerve or the C6 nerve root at the cervical spine. In those cases, aggressive local elbow treatment produces negligible improvement because the tissue being treated is not the one generating the pain signal. This misattribution is entirely avoidable with a systematic clinical assessment. The Compare Conditions tool in the link below is a structured first step you can take right now. It allows you to input your symptom location, how the pain behaves, what makes it better and worse, and how it started, and it compares your profile systematically against the most likely conditions for that area. It shows you what distinguishes each condition from the others sharing similar symptoms, what the typical treatment approach involves, and what further investigation might clarify the picture. It does not replace a clinical assessment, and it does not provide a diagnosis. What it does is help you understand the diagnostic landscape before your appointment, which makes that appointment more focused, more efficient, and more productive. Use it now from the link in the description before you assume you already know what you have.